Good morning from ESICM Lives 2025 in Munich. With me is Professor Xavier Monnet from Paris, France. And Professor Monnet has just led a group developing the new hemodynamic guidelines of the European Society of Intensive Care Medicine, which has been released at this conference and published. And I would like to talk with you about these guidelines. So first of all, you used a new methodology in these guidelines, which I found very interesting, which is tackling recommendations in cases where we don't have very strong evidence. Can you elaborate a little bit on this new technology?
Thank you very much, Thomas. New methodology. At least we knew from the very beginning that in many fields of the guidelines, we would not have large RCTs with mortality as an endpoint. And so with the panelists, we decided very early that in the absence of strong evidence, rather than saying we cannot recommend something, we would give and issue some ungraded good practice statements based on physiology, based on observational studies, and the opinion of the experts. So that facing a patient, in the middle of the night, the clinician would know what to do, knowing that there is strong evidence. Of course, everything is very clearly stated, but with solutions, with answers, despite the absence of large RCTs, once again. And in many fields, as you know, regarding shock diagnosis, hemodynamic monitoring, we don't have this strong evidence. We wanted to issue guidelines despite this absence of strong evidence.
So it's like expert opinion translated into a recommendation.
Indeed, and at each time we clearly state what are the arguments we have for stating this. That's not only the opinion of experts stated like this, It's based on something, but not large RCTs, again, with mortality as a primary endpoint.
Great. So unfortunately, we cannot go through the whole guidelines, a lot of recommendations, but what is, in big lines, the new aspects of these guidelines as compared to the previous guidelines, which have been released about 10 years ago?
There are 50 statements, so you're right, and I really invite the readers to go through all of them. Regarding shock diagnosis, we insist on the multimodal approach. It's not only blood pressure and lactate, it's also clinical examination, assessment of tissue perfusion. We recognize the value of capillary refill time, for instance, but also of biological markers. Do not rely only on one variable. Regarding hemodynamic monitoring, I would summarize the recommendations by saying assess and individualize. When the patient is severe, you must have a clear view of the hemodynamic status, not only with blood pressure and capillary refill time, and individualize your approach depending on the patient condition. And third, we recognize the value of echocardiography, which is absent from the previous guidelines almost, which of course took a very strong importance in our care of these patients with shock today.
Okay, so when we talk about hemodynamics, there are two aspects. It's blood pressure and blood flow. That is essential. Let's start with blood flow, so cardiac output. When should we measure cardiac output? When, in which patients, and how should we do that?
We suggest that cardiac output should be monitored, not in all the patients, but in the most severe patients, in patients who resist to initial treatment. Of course, there is no clear definition of this resistance, but likely patients who resist to initial fluid resuscitation in sepsis, to the initial catecholamine administration. These patients are the most severe ones, and in these patients, you must open the box and see what's inside. And that's why we suggest that in these patients, cardiac output should be monitored.
So Xavier, in patients with shock not responding to initial treatment, you recommend using either transpulmonary thermodilution or the pulmonary artery catheter to guide further treatment. Are both technologies equivalent, or when would you use the one or the other?
They are equivalent because they are both more reliable than the other ones in such severe patients with vasopressors, and because they provide a lot of hemodynamic information. Of course, they are different in the way you can use them, and because of some variables that are provided by both. Typically, transpulmonary thermodilution devices provide extravascular lung water, which is interesting in ARDS patients for managing fluid therapy. The pulmonary artery catheter provides pulmonary artery pressure, pulmonary vascular resistance. It's the only way to assess this right part of the circulation. And also with the new version of the pulmonary artery catheter, you have a continuous real-time cardiac output monitoring. With the pulmonary artery catheter as well, you have the SVO2, the true SVO2, which is not provided by the other technique. On the contrary, with transpulmonary thermodilution, you have an estimation of the cardiac function, cardiac contractility. So you see in these different variables, with these different variables, you may decide which technique is more suitable for your patient. Typically, in the guidelines, we state that in patients with ARDS without right ventricular failure, transpulmonary thermodilution may be preferred because of lung water assessment. On the contrary, we say that in patients with ARDS plus RV failure or after cardiac surgery, the pulmonary artery catheter may be preferred. So you see, you must individualize your choice. You must also take into account the skills of your team, especially for the pulmonary artery catheter. People must know how to use it before deciding to set it up in a patient.
You mentioned the right ventricular beat-to-beat cardiac output measurement. Why is that an advantage? How would you use that in clinical practice?
For me, that was the gap of the pulmonary artery catheter. No real-time cardiac output monitoring, no way to assess the effect of the fluid challenge, of passive leg raising, etc. With this technique, you have real-time cardiac output. So typically, you give fluid, you want to know if cardiac output increases, you perform passive leg raising, other tests of preload responsiveness, you can see the changes of cardiac output on the screen.
Great. So let's move to blood pressure. In the guidelines, you recommend to individualize mean arterial pressure targets in your patient. What does that mean? How should we do that?
That's a very good example of these ungraded good practice statements. Based on physiology, based on some observational studies, we say that if your patient does not improve with the initial MAP target, typically 65, think about adapt it depending on chronic hypertension. Perhaps increase the target in patients with increased CVP. Of course, adapt it in trauma patients with hemorrhage. So you see that's mainly regarding typically hypertension and CVP based on physiology. We know that there are some large trials showing that this sort of individualization may not affect outcome, but we must take into account the possible limitations of such studies. It is so difficult to translate this individualization in a protocol that could apply for hundreds of patients in a large RCT. So that's why we say you may consider adapting it to the patient condition, knowing that there is no very clear evidence, at least for chronic hypertension and CVP.
Xavier, thank you very much for giving us some insights into the new guidelines on hemodynamic monitoring from the ESICM. And congratulations again to this important work, which may influence the treatment of our patients in the future. Thank you very much.
Thank you, Thomas.